Okay, welcome everybody. I think we are now live and I'm very pleased to welcome you to this session of the All-Party Parliamentary Group on Coronavirus. We've got two panels this morning and I'm very happy to start by introducing our guests and evidence givers for panel one. And this is going to be focusing very much on the issue of equitable access to vaccines. And we have Dr. Ayode Alakija from the World Health Organization. We're very glad to have her with us again. She's the Special Envoy for the Access to COVID-19 Tools Accelerator and co-chair of the African Union's African Vaccine Delivery Alliance. We're also delighted to welcome Dr. Richard Hatchett, CEO of the Coalition for Epidemic Preparedness Innovations, CEPI, which works to accelerate the development of vaccines and other biological countermeasures against epidemic and pandemic threats so that they can be accessible to all those in need. And finally, delighted to welcome Tara Prasad from UNICEF. Since 2020, she's coordinated the UNICEF supply response to COVID-19 with the aim of improving equitable access to COVID-19 supplies in low and middle income countries. My name is Caroline Lucas, MP for Brighton Pavilion, and I've been asked to chair this session because unusually our standing chair, Leila Moran, has to put a question in Foreign Office questions more or less simultaneously. But before she does that, she's going to kick us off with our first question. So over to you, Leila.
Well, thank you, Caroline. Thank you for chairing and hello, everybody. It's lovely to see so many familiar faces who are regular contributors and also new ones too. So thank you so much. We were apprising, first of all, vaccine access. And last we had this session, the figure for vaccine access in Africa as a continent as a whole was just 4.4%. Just to set the scene, and we'll go into the details in further subsequent questions, I wondered if we could just get a picture from each of you from your perspective as to what is the percentages on the ground now and what are the running issues. Perhaps I could start with Tara, then I'll go to Richard and finally to Ayode so she's got time to settle in wherever she's moving to. So Tara.
Great. Good morning. Thank you for the opportunity to address this important evidence hearing on global vaccine access. So since the last session, we have made significant progress. The percentage of the population fully vaccinated in Africa is around 15%, according to the WHO Global Dashboard. However, there continue to be strong equity gaps in the delivery of vaccines, with only 13% of the population in low-income countries fully vaccinated, and this compares to approximately 74% of the population fully vaccinated in high-income countries and upper-middle-income countries. Now, since the last hearing, vaccine supply constraints have lifted and countries have been able to access more doses of COVID-19 vaccines. COVAX has now actually delivered over 1.5 billion doses to 146 countries, including 436 million doses to 45 countries in Africa. In addition, the African Vaccine Acquisition Trust has delivered 58 million doses to 41 countries in Africa. So COVAX now actually has access to enough COVID-19 vaccines to help protect up to 70% of the population in 91 lower income countries with donor-funded doses. And while there was an initial rapid scale-up and rollout of vaccines in countries in Africa and other regions that had previously suffered from supply constraints, on-the-ground bottlenecks quickly became apparent, including inadequate delivery infrastructure, lack of operational costs for vaccine delivery, and limited health workforce capacity. This is despite concerted efforts by national governments, supported by partners and donors, to prepare for a vaccine rollout that we all knew would be at a scale and speed unlike ever before. In addition, the risk perception of COVID has changed since the Omicron variant emerged. So many countries have actually deprioritized COVID-19 and have shifted attention to other competing priorities, such as catching up on routine immunization. Several countries with low coverage are also simultaneously dealing with other disease outbreaks and humanitarian crises. So recognizing that at the beginning of this year, the challenge had actually shifted from availability of vaccines to the delivery of vaccines. The COVID-19 Vaccine Delivery Partnership, also known as COVPD, was launched in January this year by UNICEF, WHO, and Gavi, and it specifically provides urgent financial and operational support, as well as political engagement to the 34 countries that were at or below 10% full vaccination coverage in January 2022, many of these countries of which are in Africa. And since then, progress has been made in several countries, but really at this stage, we must continue to support countries with low vaccination coverage to reach their national targets on the way to the globally set 70% target. And we need a concerted effort specifically on high priority groups, health workers, older adults, and people with comorbidities. The global community, including the UK government, continue to have an important role to play in addressing these ongoing vaccine disparities. Thank you.
Thank you, Tara. That was very comprehensive. Richard, anything to add?
It's hard to follow, Tara. That was a wonderful response. Just to maybe add a little bit of color, because she gave a very comprehensive response in terms of the actual numbers and the issues on the ground. I think I fully concur with her that the major bottleneck in 2021 for most of 2021 was certainly supply constraint. The major challenge now is on the ground delivery, and we have within COVAX shifted our attention, as Tara described, to trying to assist with delivery. The reason that's important, even as a large percentage of the global population has now been exposed to COVID, we do know that persons who have been fully vaccinated, with or without infection, are protected against the severe complications of morbidity, mortality with disease, and the most robust immunity is actually found in people who've been fully vaccinated and have had infection. And so even though many people will have had a first or even a second bout of infection, making vaccine available to all populations should still be a very high priority, but it does have to be contextualized within the challenges that the countries are facing. And so what we are trying to do within COVAX at this point and beginning to grapple with is thinking about how do we move COVID vaccination into more routine settings over time, while still targeting the populations at greatest risk and supporting countries to reach their national and hopefully the global target. So let me turn it over to Yodi at that point.
Thank you. Ode?
Hello, thank you very much, and thank you for having me. It's wonderful to be back with you. I think really it's so great to see you all, and thank you for all the incredible work as you can continue to keep this on the front of the agenda. Both Tara and Richard, who I'm delighted to see, have really made very strong and very good points. However, I will repeat some of what I've said to you before. We cannot continue to talk about the world as though it is divided into different parts. We cannot continue to talk about the world and vaccinating people in one part of the world as though they're aliens from another planet and that their health status does not affect us. So although there are challenges, although there are bottlenecks, part of the reason for those challenges and for those bottlenecks is for the conversations you as a group and myself have had in the past, that we did not plan to vaccinate the world. We planned to vaccinate some people. We planned to prioritize some lives. We chose who was going to live potentially and who was going to die. So even now, as some countries move to vaccinate toddlers and 6-month-olds, 6 to 5 months olds are now being vaccinated in some countries, there is still the argument coming from some quarters that, oh, well, should we vaccinate Africans? Should we vaccinate those in low-income countries? Or is there enough money? There's these competing priorities. So I would posit and I would argue that you cannot decide whether people have a right not to. It's not a binary equation. It's not just do you live or do you die, although we don't also have the data for that. We're seeing some data showing huge excess mortality rates, and I have discussed this with you as a group before. But of course, because our health systems are not robust enough, and that is a very valid argument, that both Tara and Richard have made, we don't know who has lived or died. We don't know who has COVID and who does not. We don't know what long COVID is going to potentially do to those populations. We don't know what it's going to do to the economically viable members of those populations. So yes, the bottlenecks and the challenges in delivery, the challenge is absolutely not supply at the moment, but the steps that got us here, the conversations we've had in the past about the initial conversations around the AstraZeneca vaccine, which we discussed in quite some detail with this group, and how that vaccine, a perfectly good vaccine, there was a lot of geopolitical, I called it a geopolitical mud fight at the time, which made people not want to take it. All of these issues have led up to where we are today, notwithstanding the weak health systems, notwithstanding the fact that there isn't enough funding being provided, both within African states and other countries, and also from the outside to support vaccination. But my final point is this: COVID is not over. I arrived in Brussels a few hours ago, had dinner with a couple of high-level people and friends and colleagues in preparation for a summit that I was to attend today. This morning, I received a text from two of them who are sick, with not just tested positive, but are actively unwell. One of them very, very worried indeed. If that is happening, back to my original point, if that is happening in Brussels, why are we assuming that it is not happening in Africa? We are not different people. We are the same continent. And what is happening in Brussels, what is happening in Africa potentially is driving the continued waves in the UK, the US, and various other places. Let me pause there. Thank you.
Thank you very much. Back over to you, Caroline.
Thanks, Leila, and thanks for such comprehensive replies. Going to Philippa Whitford now.
Thanks very much. I think what we've heard so far highlights how we have failed to take a global response to a global crisis. The WHO is working on a pandemic convention on prevention, preparedness, and response. Now, we're talking about how to bridge the gap in vaccine access now and in the future. So I'd like to ask the three of you, what kind of infrastructure do we need to put in place that might come from that convention? And how do we make sure that what we've talked about, the delivery infrastructure, but also the diagnostic and treatment equity is there? If you look, Africa always appears to have had low COVID cases, but most people in Africa have no access to COVID testing. So how do we get to look at this in the round? And if I could start with you, Iode, and then Richard, and then Tara.
Thank you, Philippa. You're absolutely correct. I mean, equity must be equity all round. And so the reason why South Africa is unfortunately in Africa given the label of having the worst cases of COVID is because they have tests. I have said frequently that the very metric by which we have measured this pandemic, and we've measured the severity and the impact of this pandemic, is in itself inequitable, because that metric has been the health systems. You know, even in the UK, for those of you who are in the UK, it has always been, well, is the NHS about to buckle? Do we have bed spaces? But for countries where there are no health systems, where the health systems are weak, where somebody in a village doesn't have a test and is basically going to die and be dug up and put in a grave, so nobody knows what they died of, where death, unfortunately, is a day-to-day occurrence, we do not know. So you make a very, very good point. Treatment equity is something that, as you know, obviously, I'm double-hatted, AVDA and also the ACT Accelerator. You know, Richard is one of my ACT Accelerator brothers, and they look after me and tolerate me in equal measure as I, scream and yell that we need equity. But we also need to be in this dynamic state of readiness. Richard smiles. We need to be prepared. Pandemic preparedness is not just let us be prepared, let us be sitting here, which we were with COVID, waiting for the next pandemic to hit us, but let us be active towards it. And so, yes, a pandemic treaty, a pandemic instrument is needed. It's one of the things that I'm here to discuss today in Brussels. It is needed, but it needs to be from the get-go. It needs to prevent, it needs to learn from the failures of the past. As Philippa just said, I mean, quite frankly, we failed. The world failed. The global health infrastructure failed. The world failed with COVID. And so what we need to do is not repeat the same thing, because the definition of madness is doing the same thing over and over again, expecting a different result. And so what is this pandemic accord or pandemic treaty? What is it going to look like? What does a dynamic state of readiness look like? I believe the British government should absolutely support it, but I believe that equity must be at its core. I believe that inclusion must be at its core. part of the reason, and part of the reason my voice and a couple of others, including people like John and Kengasong, who's now moved over to the other side, as it were, and is now with the US government, was so loud in the pandemic, was because nobody was listening to what was going on in low-income countries. Nobody understood. And so it is beyond past time that we move away from these discussions being held in, be it Geneva or Brussels, as I just told them, or London. We need to shift the center of gravity of some of these things to the countries that are hurting the most, because it is a lack of understanding of the political economy of these environments that is leading to what is going on that Tara has just described. So a pandemic treaty is desperately needed, but it must be inclusive. There must be a full consultative process with people who are actually on the ground. It cannot be directed from Geneva, from DC, from London. It must be, and it must include our voices, and it must include the bits where the shoe hurts the most. One of my favorite sayings is, as I am wearing ridiculous high heels today, is, it is the person who's wearing the shoe who knows where it hurts. And so that for me has to be the core, and it must be a dynamic process. It has to take a One Health approach, looking at, be it, and again, Richard smiles, but looking at, be it animal health, the climate. We need to look at this thing holistically, because the world we live in has shifted. I'll stop there for a moment.
Thank you. Richard?
I smile, not because I disagree with Yodi, but because we talk about these issues so very much, and we are deeply aligned. Dr. Whitford, thank you for your question. Thank you for the support that you've expressed through the pandemic for the work that we're doing. Let me pick up on a couple of things that Yodi said, and then I'll come back to the vaccine equity question. But she talked about taking a holistic understanding of the challenge the pandemic presents, and I think, and we'll probably talk about this a little bit later, it is critical to understand that the many crises that we face now have all emerged against the backdrop of the pandemic, and I even include the war in Ukraine emerging after a period of destabilization, after a period of governmental exhaustion, polarization. And then the economic crisis and the looming food crisis, inflation, all of that, traces back to roots that were established in the pandemic. So if we don't think about it holistically, we don't understand just how critical it is to address the structural roots of the inequity that we have seen emerge. Yodi also mentioned the dynamic state of readiness. That's actually, I smiled because that's a term that we've agreed on. Preparedness, we think, sounds passive. And what you really need to be is actively ready to respond quickly to emerging threats anywhere. And you need to be able to move with extreme rapidity. The vaccine inequity that has emerged, regrettably over the last year and a half, really has structural roots, I think, and it relates to where vaccine production capacity was located at the beginning of 2020. And that means North America, UK, Europe, India, and China, all with huge populations that need to be served. And there are vast parts of the world that have very little vaccine production capacity. So you asked about what kind of infrastructure needs to be in place in the future. Part of that infrastructure is manufacturing infrastructure, and we need globally, equitably distributed manufacturing capacity that is in a dynamic state of readiness, that actually already has access to the rapid response platforms that we have that are ready to initiate production quickly. The inequity that we have seen derived from scarcity and from competition for a scarce resource. If we can shorten that period of scarcity or even eliminate it altogether, then we can address the inequities that have emerged. Part of what CEPI's plans to do over the next 5 years, we've talked about the 100-day mission, accelerating vaccine development timelines down to just 100 days. Similarly, the UK government picked that up as part of its G7 presidency. It was embraced by the G7 countries, now embraced by the G20 countries. A global consensus has emerged around the need to deliver countermeasures, not just vaccines, but also therapeutics and diagnostics with great rapidity in the future. And we do need to build an infrastructure that can deliver the technical products that we need to bring pandemics under control. But even more than that, and this is where I think the discussion that Yodi was getting into around the pandemic treaty. The pandemic treaty is important for the provisions it puts in place for strengthening the IHR, of course, but it is also important for asserting a global normative consensus about how we respond to global threats. And if we can, our inability to respond as a world has produced far from optimal outcomes in the response to COVID. And if we can learn from COVID, learn how to respond to pandemics, how to respond collectively to collective threats, that will serve us well, obviously, in domains far beyond infectious disease. Thank you.
I mean, obviously, the bigger challenge we face is the climate crisis, and our failure on COVID, unfortunately, doesn't bear, bode well for that. So I think we have to learn from it. Tara, anything you want to add?
Yeah, I mean, great, thanks. I think, as has been stated, COVID has placed an unprecedented strain on healthcare systems around the world. And of course, it's exacerbated pre-existing inequalities in health service delivery. As Yodi mentioned, going forward, we need to look at equity from start to finish, R&D to manufacturing to delivering, and ensure that delivery needs in countries are considered in parallel to supply. Now, your question was around sort of some of the infrastructure needed to bridge the gaps. And of course, this depends on the specific context in a given country, but we are seeing some key areas that we need to strengthen, including availability of trained, paid health workforce, including surge capacity in place, robust supply chains, including cold chain, ultra cold chain equipment, so that countries can utilize different products, vaccine storage sites, so that countries can actually plan their country rollout and respond to ebbs and flows in demand, which is obviously the norm, and then community engagement to tackle vaccine hesitancy and build community trust in vaccination. Richard already mentioned expanded vaccine manufacturing capacity. This is obviously critical. And then in addition to preparing during peacetime, right now, as governments are working hard to scale up delivery of COVID vaccines, we can leverage this opportunity to bundle or integrate COVID-19 vaccination with other health interventions. And then we can use these investments for longer term strengthening, including future health emergencies and pandemic preparedness, as well as routine immunization. Thanks.
Thank you all very much. Back to you, Caroline.
Thanks, Philippa. Over now to Baroness Brinton.
Thank you. In April of this year, the Secretary of State for Foreign, Commonwealth and Development Affairs in the UK stated that the UK government had offered 100 million doses for donation, but global supply has obviously increased considerably. But we also know that many low-income countries have limited capacity to deploy COVID vaccines, not least when our donations arrive and they have very short expiry dates. Have we moved beyond a donation model? And could I start with Richard, please?
Thank you, Baroness, for the question. I would say that within COVAX, we have secured access. We've delivered, I believe Tara mentioned, around 1.5 billion doses. We've secured access to 2.8 billion doses, which includes the promises of the donations that we have received, as well as the advanced purchase agreements that we've been able to put in place. And for countries to reach the targets that they have set, we need to be able to deliver that vaccine. But we cannot deliver 1.3 billion doses all at once. And so the contributions to COVAX and to our work do need to be staged over time in a way that countries can receive, absorb, and distribute the vaccines. And so we do need to continue to receive the pledged donations, but we need to receive them in a staged fashion. Tara is probably much better positioned to talk about the logistics challenges that we face. But I would say that one thing that we haven't talked about, I'll just mention this because WHO the advisory group just released a recommendation about Omicron-specific variants. It is the nature of any pandemic that circumstances change over time. We are still, early in our experience with COVID. are likely to have to update our vaccines, as we are already beginning to do with Omicron over time. And we want to ensure access not just to the original vaccine and not just on a one-time basis, but in an ongoing fashion. I would say, and this is a little bit off topic, but I think it's an important point to make, and I want to make sure that everyone's aware of it. We have, through the COVID vaccine delivery program, we have delivered vaccine to many components of populations in countries that have not been recipients of vaccine previously, to adults, to the elderly, to many vulnerable adult populations. And using this bridgehead of delivering COVID vaccine to establish ongoing life course vaccination programs, to include flu, to include pneumococcal vaccines, to include other vaccines that will save lives, improve quality of life. It's absolutely essential that we build on the infrastructure that we've assembled very rapidly and secure it and help it to be a sustainable deliverer of vaccines to all aspects of the population in the future. Doing that will shape demand for vaccine. It will help provide a sustainable demand for this increased manufacturing capacity that we all believe is so essential, and it will save lives and improve quality of life over time. So to shortly answer your question, no, we're not past the donation model in my mind, and we have many, many challenges ahead of us, and we do need countries to, stay with the global effort.
Yes, thank you. Tara, next, please.
Yeah, I think Richard summed it up nicely, but just to reiterate, so we're not in the same situation that we were in 2021, but COVAX continues to work with donors as those donations can complement the COVAX portfolio in terms of the vaccine type, the volumes and availability. And also, as he mentioned, it's important that the donors support COVAX maintain a diverse portfolio, including variant adapted vaccines if they're necessary. So it's really important right now that we work with countries, manufacturers and donors to ensure delivery times for both donated and purchased doses meet country needs and their absorption capacity, and to be prepared for potential future surges. Over.
Thank you, Tara. And Iode, if you've got anything to add to that, please.
Thank you. I have a slightly different take, on this, because I'm on the ground. And about 3-4 weeks ago, I had lined up outside my offices in Abuja about 4 different ambassadors of countries that shall not be mentioned who wanted to speak to me about vaccine donations. And they wanted to basically offload vaccines that were about to not immediately expire, but they're preparing for what, and I'm glad Richard brought that up, they're preparing for the variant adaptive vaccines, they're preparing for the winter vaccination season, and they're beginning to think about donating vaccines. And so I was stunned. The reason they wanted to see me and speak to me was to ask if I would, they've spoken to Ministry of Health officials, who of course are always going to say yes please, but would I please, as an activist and as a fuss maker, not make a fuss about the about to expire vaccines when they're donated. Why am I saying this, Baroness? That the issue is that there needs to be a coordinated, as we talk about donations, this needs to be coordinated. On the ground, it is turning into a mess. On the ground, as Tara has beautifully explained, there's X billion, COVAX is donated and has been able to deliver X billion vaccines. But what Tara and Richard will not know, but that I, from sitting in Africa perspective, know, is that a few weeks ago, one state in one country in West Africa had to move about 500,000 vaccines overnight because they had been defrosted. They were going to be unable to be used, and they needed to be moved into another state, across state borders, to be used by the next day. And why? Because another batch had come in that were about ready to expire, because the appliances, the syringes for the Pfizer vaccine are different to the syringes for the AstraZeneca vaccine, because donors are not speaking to each other, because the whole equity and the pandemic and COVID has been turned into some sort of a competition or how we can offload our waste to Africa or to other parts of the world. The other point that I want to make, which might be slightly, I don't, controversial is not the word, but I think as you're politicians and you're in the political space, I think we have all underestimated the political significance of this moment, the geopolitical significance of this moment in history. I think we as a world have underestimated it. It's not about have we moved beyond the sharing or the donation model. I mean, I think we have moved beyond an us and them scenario. So now as the Ukraine crisis is coming to the fore, as food crisis, as economic crises are coming to the fore, which we spoke about over a year ago, the reason that you are not seeing the support of the UN Security Council or the UN or wherever else it is that people are voting for various, be it sanctions or be it various movements around the war, is because many of, excuse me, these countries feel let down. They feel like when we needed you, what you did was you gave us your old socks. You gave us, I don't know, those of you who've ever been in touch with missionaries, I remember the days when missionaries used to get sent old used tea bags. You know, if anybody remembers those days. And that is what we're dealing with. But the geopolitical consequences of that, donors need to get together and coordinate donations and coordinate the type of donation. So if you're going to donate AstraZeneca, a country that is prepared to receive AstraZeneca and has the syringes is able to do the delivery. So we then don't blame it on countries or on weak health systems that, well, they have weak health systems and there's workforce failures. Yes, there are workforce failures all over the place. I tried to go through Heathrow the other day and there's a workforce failure there. We're in a pandemic. So that is my answer to the question. Yeah.
That's very illuminating, all three of you. Thank you. Back to you, Caroline.
Thank you very much. I have a question now, but also a plea. Your answers are all so fantastic, but we just do need to speed up very slightly, if that's all right. And my question is about last week's WTO decision to partially waive the intellectual property on COVID-19 vaccines. Will that decision improve vaccine equity? And if so, when? Does it go anywhere near far enough? And maybe I could come to Tara first.
Great, thank you. Yeah, I mean, you know, UNICEF welcomes all efforts to lift barriers to growing and diversifying vaccine manufacturing capacity globally. But of course, intellectual property needs to be supported by technology transfer, sharing know-how, and ensuring availability of and investments in spare or scaled up manufacturing capacity. So we expect this would not yield immediate results for any manufacturers that utilize this waiver, given how complex vaccine manufacturing is and the need for the right infrastructure, workforce, stringent quality controls, as well as regulatory oversight. However, this could serve as a building block for future public health emergencies and could encourage more voluntary collaborations. Over.
Thank you very much. Come to Iode, if you had any comments on
that. Very briefly, it was too little. Too late. It should have happened a long time ago. It is not, as Tara has already said, broad enough. While one welcomes the fact that they were able to come to some agreement after all of this time, as Dr. Tedros has said repeatedly, that this instrument is meant to be used in a pandemic, it's meant to be used in an extreme emergency, and if not now, when? There were various countries that fought it to the last. I'm very sad to say and to note that the UK was one of those that was actually pushing very, very viciously against it. And I would advocate to your group that this is not the way to go for the future. It is, so that the WTO waiver is not enough. It's a beginning and maybe we can build on it, but we need to use the lessons learned from that process and from the fact that we actually have a waiver of sorts. It also needs to include diagnostics and treatments, which it does not. So it is too little, too late. Thank you that we got something moving, but we should have done it a while ago. Over.
Thank you. Yeah, I mean, just to reassure you that many of us were trying to shift the government's position for a very long time. As you say, the UK held out as one of the last people against this waiver. Richard, anything to add to that, or are we?
Actually, yes, I would like to add a little bit. I'd like to actually approach the question slightly obliquely and start by saying that I am fully in sympathy with what I understand to be the animating set of concerns that led many people to call for a TRIPS waiver. And the animating set of concerns is the recognition that it is the structural inequities in vaccine manufacturing that have produced the inequity, and it is scarcity that has produced the inequity. So the diagnosis is correct. I think Tara has spoken to, Yodi has spoken to, too little, too late. I think the TRIPS waiver in and of itself is not going to increase vaccination rates in the near term. I think it plausibly could put downward pressure on vaccine prices and could plausibly be a useful instrument for the long-term management of COVID. But for future pandemic preparedness, and many people will talk about the precedent that it presents, I think the value of a TRIPS waiver likely will be greatest for therapeutics and diagnostics because they are the kinds of countermeasures where intellectual property can often stand as a barrier for the reasons that Tara cited. Where vaccines are concerned, it is a bit, if you'll allow the Baroque analogy, like having a stone that you have to lift with two hands and trying to use that as a fly swatter. Yes, the stone can crush the fly, but if it takes a long time, then it is not providing the dynamic state of readiness that you need when you face a rapidly moving pandemic threat. And so those who supported the TRIPS waiver, please do not think that in securing even the limited TRIPS waiver that we've secured, that we have the instruments that we need to respond to future pandemics. We have to invest in addressing the structural inequity, making sure that vaccine manufacturing is available globally, that global manufacturers have access to the rapid response capabilities, and that we have built the relationships and address the regulatory challenges of rapidly developing and scaling up vaccines and scaling them up globally. And the TRIPS waiver provides an avenue to doing that, but it is in and of itself does not provide the dynamic state of readiness that we need to meet the next pandemic threat as soon as it emerges. And so it is important. It is an important precedent. It will have, I think, precedental impact. The limitation to vaccines is probably applying the instrument not to the place where it could provide the greatest value. But I think people need to be eyes open and sober about what has been achieved and what needs to be achieved for us to be prepared for the future.
Thank you. That's a really important caveat. Thank you very much for that. Let me pass over now to Baroness Masham.
Good afternoon, panel. Of the vaccines that have been delivered to LMIs, are they donated with accessible expiry dates? And are some vaccines more suitable for different countries? Could I have Tara, please?
Yes, thanks so much for the question. So adequate shelf life continues to be of paramount importance in ensuring the smooth running of COVID immunization programs at a pace that is realistic for countries. So for example, COVAX previously set a threshold for acceptable shelf life, and this was that doses must have a minimum of 10 weeks shelf life when they arrive in a country, and that applied to both donated and procured quantities. However, as we're moving into a different space now, some countries are asking for even longer shelf life to ensure they can distribute and administer the doses as they need to. And this, of course, impacts the allocation of doses to them and acceptance for specific products depending on their shelf life. So at this stage, it's really important to have open communication and coordination between COVAX and donors to ensure the most efficient usage of doses. Over.
Thank you. Dr. Richard, please.
Baroness, let me just address the second part of your question, if I might, because I think Tara gave a very nice response. But the question about, are some vaccines better suited for some countries. I think some vaccines may be better suited for some parts of the population. And so, for example, some of the later arriving vaccines, the protein-based vaccines that are administered with an immune stimulating adjuvant, like the Novavax vaccine, the vaccines that are still under development by SK Biosciences, Clover, and others, those vaccines with the adjuvant may be particularly useful in populations that are particularly vulnerable to COVID, to the immune compromised, to elderly people who have less robust immune systems. And so vaccines will evolve over time, and they may have different applications in different settings. And I do think it is critically important not to think that the tool set that we have is complete. We need more durable vaccines. We need vaccines that provide broader immunity. We need vaccines that prevent transmission. We need vaccines for particular parts of the population. And it is critically important to continue to support not just the vaccine procurement and delivery, but also the research and development of better next generation vaccines.
Thank you very much. And Dr. OAD, have you anything to add?
Thank you very much, Baroness Masham. Very, very quickly, I think that Richard and Tara have said it all. What I will say is that the virus continues to evolve, and we, as our response, both operationally and strategically and politically, must evolve with it. Richard made a very important point, which I want to reiterate around at the very beginning, around the new vaccines and the new sort of variant adaptive vaccines that are beginning to be developed. That speaks to your question as to what will be best for certain settings and what is acceptable for certain settings. You know, as the world will begin to roll out potentially variant adaptive vaccines, the messaging, we're going to have to be very careful about the messaging so that the existing vaccines, which are perfectly good, are not left behind and are not rejected by countries. So I think that for me, are all vaccines acceptable or suitable for all countries? As we've always said, any vaccine that anybody can get their hands on should be taken. But the key thing is that we need better vaccines. The world as a whole needs better vaccines. We cannot keep on this cycle of boosters and a second booster and a winter booster while some have none, because the virus will continue to mutate and variants will continue to develop in places where people remain unvaccinated. And I think we're forgetting that fact. We're forgetting that this virus is still changing, it is still moving, and we don't, even from a political perspective, we need to keep our minds open as to the countermeasures that might be population-wide measures that might be needed still in the future because we have failed to vaccinate the world. Thank you.
Thank you all so much. Back to the chair.
Thank you very much. Finally, for this session, Lord Strasburger.
Good afternoon to all of you. A very simple question from me. If the British government was sitting in the room here now, what would your key recommendation be to them? Would you like to go first, Richard?
Thank you, Lord Strasburger. I think my key recommendation to the UK government would be to understand the nature of the threat that the pandemic has presented and to understand its linkage with all of the other crises that now threaten to overwhelm us, and not to lose sight of the fact that these are threats that will recur, and they are security threats first and foremost. They are threats to health security, to economic security, and even to national security. So they should not be relegated to being funded exclusively outside of the UK by development budgets. We have to find the resources to support these that do not detract from the important global health work that we do, from the important development work that we do, but should be measured against other critical security threats and understand fully in their international dimensions.
Thank you very much for that. Very concise. Ioda, would you like to go next?
Thank you, Lord Strasburger. My point's very, very clear. I would say to the British government that you need to stop obfuscating, stop gaslighting the public, and understand that this virus and this threat remains real. and that people are getting ill, that people are dying, and it is not just within your borders, but that the actions and the message that is being sent within England also reverberates around the world. You talk about a global Britain, the countries, the Commonwealth, where the meeting is ongoing at the moment, CHOGM, is very much, many of those countries very much look to the leadership of the UK still. And unfortunately, the leadership has not stood up in this moment. The leadership has let the UK down, and the leadership is letting the rest of the world down. And I would say that the UK should therefore, government should start thinking globally. It is time to put the big boy pants on and to realize that there is global influence, that it can help shift the course of not just this pandemic, but get us in that dynamic state of readiness for the next pandemic. We cannot rely on what was a great vaccination program and the great work done by the people at Oxford and AstraZeneca and all of that. We must behave with there needs to be some certain responsible actions taken, some consequences for poor actions, and recognize that what we're doing in parts of the world like the UK are affecting low middle income countries and will eventually come back and bite us in the back. That would be my recommendation.
That's something to wish for, I think. I agree with you. And Tara.
Yeah, thank you. So, I mean, we have the opportunity to ensure that the world emerges from this pandemic stronger than before. And to achieve this, it is vital that the UK's international commitment to COVID continues, and this transfers into pandemic preparedness and response, and to not take the gas off the pedal. So, I mean, further action is still needed from donors, including the UK, to support countries to ensure they have equitable access to COVID tools, so that countries can make decisions on which tools to utilize when, based on their local epidemiology and the shifting context. This includes financial support towards the international COVID response, but also catalytic investments in countries' health and immunization systems. And it's really important that for any funds provided for COVID-19 vaccine delivery, we need flexibility so that countries can also use these funds to invest into integration and strengthening primary healthcare systems. Thank you.
Thank you very much. Back to you, Chair.
Thank you very much. And a big thank you to all of our speakers in that first session. Incredibly powerful as always. Very, very grateful to you. So you're obviously very welcome to stay, but I know that you'll all be incredibly busy, but big thanks, because that was immensely helpful. And now coming to session 2, where we're going to be looking at the situation of COVID in the UK and what we can expect over the coming months and how that differs across the globe. We have 2 witnesses in this session. We're delighted to welcome back Dr. Kit Yates, who is Senior Lecturer in Mathematics and Co-Director of the Centre for Mathematical Biology at the University of Bath, and Professor Martin Antonio from the London School of Health and Tropical Medicine, he is the MRC investigator and co-director of the Centre for Epidemic Preparedness and Response. So we're delighted to have both of you with us. And if it's all right, I will kick off with the first question. I'm just checking that Professor Martin is with us. Professor Martin Antonio, is your video working?
Yes.
Marvelous. Good.
I don't know if you can see me. Yeah.
Yes, we can see you now. It makes me feel a lot more confident. Thank you very much. You're very welcome. And my first question, maybe which I could put to you first, would be that last week we saw an increase in the number of patients in hospitals with COVID-19, but also the number of hospital-acquired COVID cases rising as well. And I wonder if you agree with the reports which suggest that we're seeing a new wave, and is this something that we need to be prepared for going forward?
Thank you so much. I'm so sorry. I hope the question is directed to me, Martin Antonio. And if so, I really want to thank the committee for the opportunity to appear before you. So just to clarify that I'm based in the MRC unit in the Gambia, so I'm speaking from Banjul. So you are aware. And thanks so much for the question as well. I think it's really important for the global community to monitor the pandemic as it goes along. And it is true that one of the ways to measure the impact of the viral infection is to conduct whole genome sequencing to determine whether a new wave is emerging. And I'm not an epidemiologist, but my epidemiological colleagues do predict that we should expect a new wave of COVID-19. And so, but as a lab person, what I also recommend is that we need to support the whole genome sequencing effort in order for us to be able to determine whether a new wave will emerge or not. Thank you.
Thank you very much. And coming to Dr. Yates, maybe for a UK specific response to that question. Thank you.
Absolutely. So I think in the UK, we're undoubtedly now in a new wave. It's the third wave we've experienced in the UK in the last 6 months, which is sort of unbelievable to think. We've seen increases in the proportion of people testing positive across the 4 home nations of the UK. So the last ONS infection survey, which is a randomised survey of the population, so it doesn't depend on who's testing, that goes up to the 11th of June, and that shows that we're seeing rises in cases across every region of England as well, and across every age group. And actually, we've been expecting this in the UK for a while now. We've been watching these 2 new variants, BA4 and 5, grow in terms of their proportion of sequenced cases. We get that from the COVID UK Genomics Consortium data. So BA4 and 5 combined have now overtaken BA2 and its subvariants, the variants of Omicron that caused the previous wave. There has been a particularly large rise in the last week on week on the ONS infection survey. In part, that might be due to increased mixing due to the Jubilee celebrations, but we were expecting to see upticks, and indeed we were already seeing them before the Jubilee weekend. In terms of hospitalizations, we're seeing increases in the number of people who are in hospital, both primarily for COVID and in the number of people who are in hospital with COVID, if you like, as a sort of secondary or not as a primary donation. Some of that second group will have acquired COVID in hospital, in particular recently, because many hospital trusts have been removing masks, which seems like an absolutely crazy idea when we have this setting where the most vulnerable people have to attend. We have a crisis with healthcare workers being impacted by COVID and long COVID. So, that removal of masks does not seem like a sensible idea in hospital trusts, especially in the face of an oncoming wave. It's also worth bearing in mind that some of these people who are not in there primarily because of COVID may have COVID as an underlying cause. So they may be in there being treated for a stroke, but that stroke may have been caused by COVID. So it's worth bearing that in mind as well. So it's clear that we're in a new wave. What's not clear about this wave is how large or how severe this wave is going to be. And we hope that it's going to be low, but we really can't tell at the moment.
Thank you very much. That's depressing but helpful. Let me pass on now to Baroness Brinton.
Thank you very much. If I could turn to Kit first to do the UK and then come on to Martin after that. So in the UK, given the threat we had to ONS testing and the problem that the Zoe testing have already got with not enough people responding, are we doing enough testing, first of all, to be able to do the genomics effectively, but also to manage outbreaks? And what should we be doing, as you've just described, cases going up with BA and 4? And what do we know about things like long COVID and the new variants?
So with the new variants, we're at an early stage to say what we know and don't know about them necessarily. There was a study, when we have these new variants, there are 3 things we typically want to know. Is it more transmissible? Does it evade existing immunity? And is it more severe? There's no evidence at the moment that it's more severe, but it is clearly spreading where other variants aren't. So there's either inherent improvements in transmissibility, or more likely it's evading existing immunity. Omicron is the most transmissible version of COVID that we've seen so far. It's one of the most transmissible diseases that we have on the planet, in fact. There's a study out from Imperial last week which suggests that boosted people, people who've had the booster, will have a similar response to BA4 and 5 as they did to BA1 and 2. But we obviously saw big waves of BA1 and 2 with lots of people in hospital and lots of people dying, unfortunately. Of course, now people are further away from their booster, typically, apart from the over 75s in the UK, who were, most of whom were at least offered a booster in the spring. And in terms of reinfection, so people who've been infected with Delta, that gives you the least protection against these new variants, because it's just so different. People with infected with BA1, which was over December and January, that provides less protection against these new variants, BA4 and 5, than it did against BA2, which was the wave that we had in March and April. And then being infected with BA2 provides the best protection. In fact, the best protection, as we heard in the previous session, is actually having the booster and infection with Omicron. But of course, it doesn't make sense to suggest that people go out and get infected in order to protect themselves from getting infected. So, really, I think we should be thinking about boosting people in order to provide protection. The other place we can look to find out about what's going on is to other countries, although of course now every country has a sort of unique history in terms of what's happened in that country, what waves they've experienced, what they've done in terms of vaccinations. So in South Africa, we've seen a relatively low wave of hospitalizations with BA4, 5, but in Portugal, we saw them reaching around 80% of the hospitalizations that they had with their BA1 wave earlier in the year. Now, neither Portugal nor South Africa had a big BA2 wave as we have done, so it might be hoped that we have built up some protection. This wave will not be huge, but potentially, this wave is taking off, and it's going to mean more people being infected, more people having time off work, more people getting impacted with in the future with long COVID, which is a significant issue.
Thank you very much, and Martin.
Right. Thanks again for the question. I completely agree with what Dr. Yes have just said, but it's also to emphasize that the sub-lineages of BA4 and 5 are actually sub-lineages of Omicron, and so there's only about 3 point mutation differences that lead to amino acid changes in these sub-lineages. So it is a version of Omicron. It's really important. And it is true that this sub-lineages do differ from geographic region to the other. But it is also important to emphasize that this sub-lineages, you don't need a visa to cross from one country to the other. And all you need to do is to get onto an aeroplane and then travel from, say, Africa to Europe or to the US, and then this sub-lineages could spread. So it is really important to understand this aspect. So I just wanted to add on to what Dr. Yes have said. Thank you.
Thank you. Back to you, Caroline.
Thank you very much. Let me give the floor to Baroness Mushin.
Hello, everybody. What level of protection does the UK population have now against new variants? Do we now, or at any point in the future, need another booster campaign in the UK? And how long does the vaccine protect a person for? Could I have Dr. Kitt, please?
Hi, thanks for the question. So I'll point out that I'm not a vaccine expert. I was expecting we'd have Professor Pollard here as well to speak to vaccines, but I can speak a little bit about vaccines. So certainly this recent Imperial study found that boosted people have a similar response to BA4-5 as they did to BA1-2, but we know that protection from the vaccines does wane over time. We've seen that giving one or a full dose, what we originally called a full dose of vaccines, 2 doses, is not enough, and we boosted people over Christmas, and that did make a difference. But again, that protection is wearing off, and in particular, we don't have Omicron specific variants, or at least we're not delivering Omicron specific vaccines in the UK at the moment. So there's definitely an argument for boosting the population, particularly older generations. This is a matter on which in the UK, the JCVI, the Joint Committee on Vaccination Immunisation, will advise upon. And they have made recommendations for the autumn. I don't know what their current remit is, whether they're allowed to consider costs as they often do, or whether it's just considering health benefit. But currently their recommendations are to vaccinate residents in care homes for adults and their staff who work there, frontline health and social care workers, everyone over 65, and then people between 60 and 64 who are in a clinical risk group. So no one who is between 60 and 64 who's not in a clinical risk group. So these are the people that we know are getting long COVID, for example. Unfortunately, the JCVI don't release their minutes in a particularly timely manner in order for us to be able to scrutinise their decisions, and they don't release the modelling so that we can scrutinise where these decisions come from in a timely manner. So it seems from the minutes that we've seen so far is that they don't really consider long COVID as being a significant issue in their calculations, which I think is, in my opinion, is a mistake. I think actually it's not particularly good scientific practice. So I'd like to see the JCVI, who are taking decisions which affect everyone in the entire nation, I'd like to see them make their decisions and their reasoning open to public scrutiny. I think that's the best scientific practice. So if they're going to make those recommendations to not vaccinate everyone in the autumn, we'd like to see where that comes from. Similarly with their decisions not to vaccinate under 16-year-olds, again, we'd like to see where those decisions come from so we can see if they're robust and to see what they're actually considering in their models. But there's certainly an argument for boosting people in the autumn for sure.
Can I just ask you a supplementary, which is if you've had booster 4 some months ago, should you now be having a booster 5?
So I think the JCVI are going to recommend that in autumn that everyone over 65 has a booster. So that's people who are offered booster 4, the 4th dose, if you like, were the over 75s this spring. So yes, they will be recommended to have this booster in the autumn as well.
Thank you so much. And Professor Martin?
Yeah, again, just like Dr. Yeda mentioned, I was hoping that Professor Paula will be here to answer that because he's the vaccine expert. But I can answer a little bit. I completely agree that targeting high-risk groups for booster vaccination should be one of the key priorities for the UK government. And in addition to that, we also have to be thinking about children, especially in developing countries, and individuals that are high risk for potential vaccines as well. Thank you very much.
Thank you. Back to the chair.
Thank you. And just to say, we had indeed hoped that Professor Pollard was going to be with us this morning, but unfortunately he's not been able to join us. He's not well, so that's why he's not here. But I will pass over.
Yeah.
Let me pass over now to Philippa Whitford.
Thanks very much, Caroline. This is a question for Martin. Specifically, the WHO is obviously now beginning consultation and discussion around a pandemic convention, trying to look at prevention as well as preparedness and response, because obviously we really haven't done very well on either our preparedness or our response with COVID. Do you think the UK government is collaborating sufficiently with international organisations so that we are front and centre in both the domestic and international pandemic preparedness?
Thank you so much for the question, and this is really very interesting. Now, as you are aware, the UK government supports what we call the UK Public Health Rapid Support Team, which is co-led by my own university, the London School of Hygiene and Tropical Medicine, and then the Public Health England arm. is funded through the UK government, overseas and development aid. And the mission of that is really to prepare, respond, and also to conduct research as well as capacity development of outbreaks in low and middle income countries. Now, the question is whether the UK government is collaborating enough with global agencies in order to do that. I mean, I can answer that in two parts. The simple answer, so far as I'm concerned, is that I don't think so. I think the UK government could do a bit more, given that post Brexit, the slogan is to go global. And for me, I see pandemic preparedness and, of course, response as a way that developing countries in the 50s energized to obtain independence from the British government. I think that the government will have to do a bit more in research. Now, there are pockets of research that are occurring in the developing countries. There are a few in Africa, but so far I'm concerned, it's not substantive enough. Luckily, part of the new Center of Pandemic Preparedness and Response at the London School is trying to address the research and capacity building out. And the idea is to decolonize the way sciences perform so that we have equitable partnership with countries in Africa. And this is done through what we now refer to as the Peter Piot Fellowship, to train young scientists and researchers in developing countries in order to be able to respond to future threats of pandemics. So the simple answer is I wish the UK government could do a bit more. And I don't want to compare pandemic preparedness with the military, but I see sort of a parallel structure to this. If we put our mind to it and spend a bit more money and focus the way we spend more money in the Ministry of Defense, I'm sure we will be able to address some of this in the future. Thanks, and I'm happy to add a bit more.
I mean, clearly biosecurity or bioresilience and the need for it's been highlighted by the fact our societies and economies have been brought to a shuddering halt by COVID. But you talk about partnership research. Has that not been significantly impacted by the cuts to ODA funding, which through the Research Institute and universities has actually unfunded research projects, including indeed even some COVID ones?
It is indeed, and I was trying to politically stay out of this because I'm a scientist, but you are absolutely right. And the cut in OD funding has really affected the way universities operate. And globally, my own university, and I have some researchers myself, that funding were cut, so they were not able to conduct their own research. You may know that the African Academy of Sciences do receive some funding through the UK government. That has also impacted heavily on that. So the collaboration with African CDC through the African Academy of Sciences, through the Medical Research Council, which was established by the UK government based in the Gambia and in Uganda, they are all impacted on that decision. And so, and having, so it's not by accident. No, the young researchers in Africa and UK and other places are really energized. And I'm sure you put resources into some of the research that are planned and that are taking place to alleviate and prepare for future outbreaks. So I completely agree with that. Thanks.
Thank you very much. Back to you, Caroline.
Thank you so much. I was going to ask the question now just quickly about the view of the WTO decision. It's the same question I asked the first panel, but I wonder if you could share any views you have about whether you think the decision last week of the WTO to partially waive IP on COVID-19 vaccines went far enough? How much will it do to improve vaccine equity? And if it will, then when might we see some result of that? I don't know if I could start with you, Dr. Yates.
Yeah, absolutely. So I think the story is probably, but this is a welcome first step, and I don't want to reiterate too many of the points of the first session. It should enable more localized production, but although the recipes for vaccines have been shared, the know-how, the tech transfer has not been as part of this agreement. It's also worth noting that antiviral drugs and diagnostics are excluded from the agreement as well. As as it stands, it looks like too little and certainly too late as well. I think overall in the UK, it's sort of embarrassing that we were almost the last holdouts to this agreement on Thursday. I don't think that we've distinguished ourselves on the international stage. Huge swathes of the world's population remain unvaccinated, and even from a UK-centric point of view, while people remain unvaccinated, COVID is allowed to spread. And we're going to continue to face problems brought about by new variants here in the UK. So even, it seems short-sighted, even if you just consider a UK perspective, quite apart from considering the global perspective. We have this mantra in the group that I'm a contributor to, Independent Sage, that no one is safe until everyone is safe. And I think that that holds true here. And I think we could and should have been doing more, and we should have been doing it earlier.
Thank you very much. Professor Antonio, would you like to add anything to that?
Yes, I quite agree. I think that it is a welcome news, but it's a bit late. And I wish that instead of partial waiver, it should be absolutely full waiver. Because as I mentioned previously, infectious disease doesn't need visas to cross various borders. And we need to be serious about global health. We need to be absolutely serious and waive all, as far as I'm concerned, if it's to do with pandemic or epidemic, we should waive all rights so that poor countries, as well as rich countries, of course, can be able to design vaccines and manufacture the vaccine their own people. Yes. And this for me is an issue about equity, access, and of course, of course, decolonizing science. We've been talking about decolonization, and I think this goes to the heart of the matter. Thank you so much.
Thank you so much. I think, Philippa Whitford, we're back to you just for another question just now.
Yeah, thanks very much. If I could start with Martin on this one. Obviously, all the legal restrictions have been removed across the UK, and particularly the message at Westminster is still very much COVID is over. There is talk about what we do next autumn and winter, but as we touched on in session 1 and is clear from the data, actually we are in another wave, regardless of what size it is, with BA4, BA5. So what do you think we should be prioritizing now? The vaccines are not necessarily preventing people catching it. So should we be finally investing in ventilation? Should we be bringing back masks, or are there other measures we should be doing now and in the autumn and winter? So if I can start with yourself and then Kit, please.
Right. Thank you so much for the question. The way I'd like the committee to perceive this particular question is to think of COVID-19 as the way we think about flu. And so it is now clear that it's becoming an endemic disease rather than thinking of it as an outbreak. And if we do, we should be targeting high priority individuals within our society that may be exposed. And of course, I completely agree that we need to bring in our engineers to think quite cleverly how to design buildings where ventilation will be key. As you know, in developed countries, a lot of individuals spend a lot of time outside, and that may explain partly why the transmission of COVID-19 is slightly less than in an enclosed area. So yes, so I completely agree that we should have a very strong collaboration with engineers to think about ventilation. But we should now be thinking that COVID-19 is an endemic disease, and we should give high priority to individuals that will be exposed. Thank you.
The only problem, of course, is that it's how out with vaccinating high priority or high risk people. How do we give them priority once everyone else stops wearing masks and is mixing and isn't washing their hands, etc.? The two things that have been shown to make a big difference in spread, then obviously that exposes those high risk people. So how do we balance that exposure of high risk people against kind of, if you like, freedom for everyone else without putting high risk people stuck back shielding in their houses?
It's a very interesting political question, which I'm trying to stay clearly from politics. But you are absolutely right. We know from all the scientific literature that behavior changes is one of the key aspects in curbing the infection through social distancing, mask wearing, etc., going to airports, etc., etc. But I also do understand from the government perspective about the economy in terms of opening up and releasing travel restriction, which, by the way, was never endorsed by the WHO, because we know that once travel are restricted, those in low-income countries do even suffer more because of visa restrictions and shipment of reagents for conducting testing for the pathogens that we are interested in. So it's a bit tricky, and I think it is a balancing act. I will recommend that we listen to the scientists first and foremost, and then bring in the politics. So I want to prescribe a global solution to this. I think we have to look at this region by region. So if you look at the UK, you can look at England, Scotland, Ireland, etc., and then decide how we can develop policies to combat this pandemic, and then we can introduce that. So if you feel that infection rate is really high in a particular region, and we may have to introduce mask wearing, and so far as public transport is concerned, as an example, then we've got to think about that. But you got to think of it region by region, and also within African population elsewhere, you got to think of it that way. So I'm not sure whether I've answered your question, but again, I'm trying to stay away from politics. Thanks.
Okay, if I can come to yourself now, Kit. I mean, in England, testing of patients coming into hospital is stopped, and now mask wearing, other than in the normal areas, has also stopped. Do you think some of these things should be coming back as we're seeing a rise even in hospital-acquired COVID? Are we just ignoring it too much, or should we be doing more now rather than just in the autumn?
I mean, yeah, I don't mind jumping in and saying something political. I think we should, in many instances, not have undone some of the things that we did back in March. So I think we should still be allowing people to test for free to know whether they're impacted or not. We should be strongly encouraging people and supporting people to isolate when they're infected, so that they don't have to face difficult decisions about whether they go to work to get money to put food on the table, or whether they infect their colleagues. I think mask wearing in indoor public spaces is a sensible measure. We've seen that through the attitudes of some of the members of the House of Commons, that's not taken very seriously, unfortunately. But mask wearing is not economically costly, and it's something that we can be doing, in particular in healthcare settings. You talked about vulnerable people. Back in October 2020, there was a movement called the Great Barrington Declaration, which said we should just basically shield all the vulnerable people and then let everyone else crack on. And of course, there are many, many reasons why that would have been a terrible idea. Healthcare would have been overwhelmed. It's not actually practical to do that. But that's de facto what is happening to vulnerable people at the moment. They're being forced to isolate and not go to public spaces where they might get infected with high prevalence levels as they are at the moment. So I'd like to see lots of those things happening, but I'm realistic. I'm a realist, and I think, you know, we need to be taking long-term measures so that if and when COVID does become genuinely endemic, rather than these cycling waves that we're seeing at the moment in the UK, that we have low-level endemicity rather than high-level endemicity. So I think we should be improving indoor air quality. We know that indoor is much more, there's much more risk of transmission indoor than there is outdoor. So we need to be making indoor air quality more like outdoor air quality. So through things like ventilation, but also filtration, UV treatment, and there are things that can be done there. The government needs to be taking charge of that in terms of public spaces like schools. We need to be doing better in schools because we know that there's lots of transmission which happens in schools, and also potentially providing grants to businesses to make businesses and workplaces, places where people work, safe from getting infected. And part of that is also improving sick pay across the UK. So Boris Johnson said in February that when people are unwell, we should be taking a leaf out of, you know, what people are doing in Germany and staying at home when we're not well. The reason people in Germany stay at home when they're not well is because they have one of the best sick pay regimes of any OECD country. You know, employers are required to pay 100% salary for the first 6 weeks of illness, whereas in the UK, we get just £96.35 a week, which is less than a quarter of a typical salary. So if we want people to isolate when they're unwell, not to spread the disease, then we need to tackle these structural issues. So there are short-term things we can be doing to reduce transmission, but there are also long-term structural things that we can and should be doing now to prepare us for the future.
Yeah, despite repeated calls, we can't even get the Chancellor to remove VAT on ventilation and air purification systems, which kind of would seem like an obvious first step. Thank you both. Back to you, Caroline.
Thanks very much, Philippa. Let me give the floor now to Barbara Keeley.
Thanks, Caroline. Thanks, Chair. And this is another question. We keep touching questions on vaccines with you, Dr. Yates and Professor Antonio. I know that you said that you were going to defer to Andrew Pollard on this, but my question is about becoming aware, the British public becoming aware about next generation vaccines to deal with new COVID variants. So insofar as you can answer, can you tell us what stage you think we're at regarding the development of those next generation vaccines, and how instrumental that will be in looking at continued mitigation against COVID-19? Can I start with you, Dr. Yates?
Yeah, I'll admit that this is not my area of expertise, so I won't speak long about it. I'll just say we have been told about variant-specific vaccines, and obviously it would be great to have vaccines which are even more effective at reducing death, hospitalization, and of course transmission. We were told, early on last year when Omicron first came about, that we would be able to have these vaccines developed very quickly, but clearly that hasn't happened. The rollout hasn't happened as quickly as we might like. But I think there's still a role for them, and new updated vaccines, potentially nasal vaccines as well, that we can deliver easily across the population would be a really, really great thing to have. But further than that, I can't speak to it.
Yeah, okay, thank you. Professor Antonio.
Yeah, again, thanks for the question. And just like with Dr. Yates, this is not my area of expertise, but in principle, and just like any other vaccines, they need to be updated every so often. I do know that there are several companies as well as UK Research Institute like Oxford that are really busy to improve on the current vaccine. But let's not get away from the question about us. Even the current vaccines that are available are not accessible to poor nations. So we got to also think about that aspect, how we could make accessibility of vaccines to individuals in low-income countries. Thanks.
Thank you. Thanks, both. Back to you, Chair.
Barbara, and finally to Lord Strasburger.
Well, you timed that well, because I've just lost signal for about a minute, but I just came back. The final question is the same as the one with the previous session, which is if the government were here in the room with us today, what would be your key recommendation to them? Would you like to go first, Kit?
Yeah, absolutely. So I think I'd start with my key message would be that COVID, as much as we would love it to have done, has not gone away. much as we'd like to pretend it has. And in particular, we haven't talked about it much today, but long COVID is a growing issue, and it's something which makes it not okay to allow spread, even if we can reduce hospitalizations, pressure on the NHS, which is extreme at the moment as it stands, and deaths. Long COVID is a significant issue, which is affecting at the moment 2 million people in the UK, 400,000 of whom say it affects their day-to-day activities significantly. It's not going away. So I think there are things that we need to do to reduce the levels of transmission, including messaging, good public health messaging on things like mask wearing, that mask wearing is effective, ventilation, improving vaccinations and getting people to get vaccinated, sick pay that I've already mentioned, and of course, global vaccine equity, because of course, despite what our former Health Secretary Matt Hancock has said, you can't unilaterally declare yourself out of a pandemic. It's a global problem by necessity, and so we have to try and tackle it as a global issue. The other thing is that, again, it has to be tackled over time, but we need to tackle inequality in this country. We've heard lots from politicians throughout the pandemic that we're all in the same boat with COVID, and this is just demonstrably not true. The poorest sections of society were hit hardest throughout the pandemic, and they tend to be, as they tend to be usually with the majority of health issues, and we're not doing enough to tackle inequality. So, I think that the message is that with COVID, we're all facing the same storm, but some of us are in super yachts and some of us are in dinghies, unfortunately. Thanks. Oh, you're on mute.
Sorry, yep. This committee's taken a very close interest in long COVID, and so I'm sure we'd all endorse what you've just said. Martin, your key recommendation.
Thank you so much, Lord. And mine is not dissimilar from Dr. Yates, but I really want the UK government to start thinking globally. As I mentioned previously in my testimony, the UK government had a slogan that it's going to be a global Britain. So far as pandemics is concerned, it doesn't seem that case to me as a researcher, and I would like to see the research funding for young researchers in low and income countries to be increased so that they will be able to perform research locally, and then their work will have global implication. For me, this is so important, and it will reduce inequalities so far as research and pandemic preparedness is concerned. So my message is that we have to think globally, and we need to increase funding for research, for both training and also for research. Thank you very much.
Thank you very much for that very clear message. Back to you, Chair.
Thank you so much. That brings us to the end of our second panel. So big thanks again to Dr. Yates and Professor Antonio for really powerful and compelling evidence. Very grateful to you for giving us your valuable time this morning, and we will do our very best to make sure that we gather up those very strong recommendations and present them to government as soon as we can. So very, very many thanks, and thanks to my colleagues.
And thank you so much. Thank you all. Bye-bye.
See you soon.